Internal factors: knowledge, training, beliefs and values, emotions, sleep or fatigue, stress, physical illness, personality type. It leads to type 1 thinking or conservative conservation of cognitive effort, cognitive and affective biases. External factors: interruptions, cognitive overload, time pressure, ambient conditions, insufficient data, team factors, patient factors, poor feedback. This also leads to type 1 thinking, and this leads to error. Figure 1.8: factors that affect our judgment and decision making. Type 1 thinking is equal fast, intuitive, subconscious, low effort. Several studies demonstrate that we focus our attention to filter out distractions. This is advantageous in many situations, for example, when performing a procedure, but in focusing on what we are trying to see, we may not notice the unexpected. In a team context, what is obvious to one person may be completely missed by someone else. Safe and effective team communication therefore requires us never to assume and to verbalize things even though they may seem obvious. Shared decision making. Shared decision making refers to the fact that clinical reasoning does not necessarily take place solely within a clinician's head. Good decision making is often shared with patients, relatives, and carers within teams and by using guidelines, clinical prediction rules, and other decision aids. Integral to all of this is the ability to engage in optimal decision making behaviors involving the patient and or carers in the diagnostic and management process. Listening to others, following evidence based guidelines, asking for help when needed, and using clear communication, especially when hand, handing over care. Patient centered evidence based medicine. Patient centered evidence based medicine refers to the application of best available research evidence while taking individual patient factors into account. These include both clinical and non clinical factors, example, the patient's social circumstances, values, and wishes. For example, a 95-year-old man with dementia and a recent gastrointestinal bleed is admitted with an inferior myocardial infarction. He is clinically well. Should he be treated with dual antiplatelet therapy and low molecular weight heparin as recommended in clinical guidelines? As this chapter has described, clinicians frequently deal with uncertainty or probability. Clinicians need to be able to explain risk and benefits of treatment in an accurate and understandable way. Providing the relevant statistics is seldom sufficient to guide decision making because a patient's perception of risks may be influenced by irrational factors as well as individual values. Research evidence provides statistics, but this can be confusing. Terms such as common and rare are nebulous. Whenever possible, clinicians should quote numerical information using consistent denominators. Example: 90 out of 100 patients who have this operation feel much better. One will die during the operation, and two will suffer a stroke. Visual aids can be used to present complex statistical information. How uncertainty is conveyed to patients is important. Many studies demonstrate a correlation between effective clinician patient communication and improved health outcomes. If patients feel they have been listened to and understand the problem and proposed treatment plan, they are more likely to follow the plan and less likely to re-attend. Effective team communication. In increasingly complex healthcare systems, patients are looked after by a wide variety of professionals, each of whom has access to important information required to make clinical decisions. Strict hierarchies are hazardous to patient safety if certain members of the team do not feel able to speak up. The SBAR system of communication has been recommended by the UK's Patient Safety First campaign. It is a structured way to communicate about a patient with another healthcare professional, example during handover or when making a referral, and increases the amount of relevant information being communicated in a shorter time. It is illustrated in box 1.7. Using clinical prediction rules and other decision aids. A clinical prediction rule is a statistical model of the diagnostic process. When clinical prediction rules are matched against the opinion of experts, the model usually outperforms the experts because it is applied consistently in each case. However, it is important that clinical prediction rules are used correctly, that is, applied to the patient population that was used to create the rule. Clinical prediction rules force a scientific assessment of the patient's symptoms, signs, and other data to develop a numerical probability of a disease or an outcome. They help clinicians to estimate probability more accurately. A good example of a clinical prediction rule is to estimate pre-test probability is the Wells score in suspected deep vein thrombosis. See box 9.18. Other commonly used clinical prediction rules predict outcomes and therefore guide the management plan. These include the GRACE score in acute coronary syndromes, see figure 16.61, and CARB 65 score in community acquired pneumonia, see figure 17.32. Reducing errors in clinical decision making, deliberate practice. Studies of expertise reveal that extensive experience is necessary to achieve high levels of performance, but extensive experience does not by itself lead to expert levels of achievement. Something else is required, encapsulated in the term deliberate practice. This involves effortful practice, coaching, and feedback, and the ability of an individual to plan, assess, reflect, and adjust so their performance improves. Cognitive debiasing strategies. Knowledge and experience alone, however, do not eliminate errors. There are some simple and established techniques that can be used to avoid cognitive biases and errors in clinical decision making. History and physical examination. Taking a history and performing a physical examination may seem obvious, but these are sometimes carried out inadequately. This is the unpacking principle. Failure to unpack all the available information means things can be missed and lead to error.